Rucaparib is a PARP inhibitor. The mechanism of action of PARP inhibitors is blocking one of the pathways that are in charge of repairing DNA. Why they work? That's the only family of drugs that they've been found based on what we call synthetic lethal toxicity. What does it explain? So one of the hallmarks of cancer is having defects on DNA repair genes. That makes that because some of the DNA repairs are missing, some of other DNA repair pathways are taking the lead to try to preserve the DNA integrity. So in these tumor cells where that's happening, if we block one of these DNA repair that might be taking the lead to repair this DNA, then the cell crashes, it's not able to repair the DNA and it just die. We know that up to 12% of the patients with prostate cancer have these defects already in the germline. Seems like it's much higher in somatic. That means that the tumor itself is acquiring these DNA defects while they appear and they progress, and that's what we use to treat cancer. The TRITON2 study are showing us really encouraging and interesting data. What we can see from this data is that the most important mutations that we find in these DNA repair genes, that's BRCA1, BRCA2, that it's highly mutated in some groups of these patients. They're really getting benefit from these drugs. We are observing almost a 50% rate of response rate, and a 50% a little over 15% PSA response rate. Just to make you an idea, some of the drugs that we have already approved and we are using in the clinical practice in the same setting after the Taxol show much less results, and they're already approved. So this is a big breakthrough because it opened a window of opportunities for treating patients with prostate cancer. The generic screening of TRITON2, TRITON3, I think they've been really smart trying to implement a plasma test. We know that prostate cancer can be tough to obtain biopsies. A lot of these patients have only bone disease. Bone disease, we know that's hard to biopsy, and sometimes even we do the biopsy, we do not obtain tumor cells. The archival tissue, sometimes it's really hard to interpret as well, because we're talking about patients with a long natural history. So sometimes what we've seen trying to send material to do the screening is that we are requesting tumor blocks that were obtained like 10, even 15 years ago. So if that represents what's really happening now, that's hard to believe that's really happening. So I think the plasma test, what's showing us is it's feasible. We still need more data and we have to still increase the number of patients. But I think with the samples that we're obtaining in both clinical trial, TRITON3, we're going to be able to answer that question. Well, the clinical implications of the findings, now we have to we're still recruiting patients. The clinical trial is still, both clinical trials are still ongoing. What the results are saying is that here this drug seems to be active. It's active in prostate cancer patients with, that harbor these kind of mutations. We still have to recruit more patients. We have to, thanks to the results of the clinical trials, we're going to see even which patients are getting more benefits on the others, so we'll be able to really select better the population. And as I said, the clinical implications is that we're going to have another active line of treatment for a group of patients that have especially bad prognosis. Several of the studies that are being performed, they're being published, they're being presented, where they're showing that this population of patients that harbors BRCA2 mutations, for example, they tend to be more aggressive and more resistant to other kind of treatments that we're using in prostate cancer. What we're seeing now is just the tip of the iceberg. No, we are treating, so the results, the clinical results we have in TRITON2 are patients who already received the standard treatment. So there are patients that there's no really standard treatment for these patients other than getting to the clinical trial. We're doing the TRITON3 clinical study too, that's in an earlier setting. There's patients that only receive one line of hormone. And what we know in oncology is usually active drugs, when they're moved forward, they tend to be more active and the results are better. And we have to put on the mirror too what's happening in other diseases where these drugs are active, like ovarian cancer. We started treating germline mutants only. Now we know that somatic disease doesn't make much difference. And the later results with PARP inhibitors in ovarian cancer are saying that even patients without any of these mutations are getting benefit. Then too, the second wave of studies might be combinations, for example. We know that this drug could synergize preclinically with other drugs that are widely used in cancer as well. And the objective at the end is to try to increase the population of patients that are getting benefit with these drugs.